Hi, everyone, and welcome to our third webinar from the Texas Collaborative for Healthy Mothers and Babies on maternal early warning systems. We want to welcome all the Texas AIM hospitals who are participating today. Thank you for joining us. Today's webinar will focus on implementation, specifically strategies to integrate maternal early warning systems with electronic health records, and how to collect and use data to improve your system. My name is Amanda Wagner. I am the Quality Improvement Nurse for TCHMB, and I will be facilitating today's webinar. Before we get started, I want to point out the chat box and the Q&A features of the Zoom webinar. Please, both of these are available for you to use if you have any questions or if you want to leave comments during the presentation. In most cases, questions that come in during the presentation will be answered during the Q&A session at the end. Our presenters today include our obstetrics subcommittee co-chairs, Dr. Christina Davidson and Dr. Carrie Epps. And our objectives are to review maternal early warning systems in general, illustrate integration examples for the electronic health record, discuss how data can assist with implementation, and then close with a period of Q&A. So to briefly review, maternal early warning systems are a system of escalation based on maternal vital signs. They were developed to facilitate timely recognition, diagnosis, and treatment for women developing critical illness. Numerous maternal mortality committees, including ours in Texas, have found that delays in recognition and response to abnormal vital signs represent a significant preventable cause of maternal deaths. We recognize the Texas AIM teams have been working on OB hemorrhage, and the maternal early warning system component is essential to the readiness, recognition, and response phases of this bundle. This algorithm is an example of the overall MEWS process. It begins with maternal vital signs, which each facility will need to define for their setting, and then educate all caregivers and patients about these triggers. These MEWS-specific triggers lead to a notification process, which is illustrated here as trigger MEWS, and that notification process should lead to a defined and required response. This response could include having the provider at bedside to evaluate the patient within 15 minutes, or for facilities without in-house providers, it may include activating a delegated order set for MEWS, and then having the provider at bedside within 60 minutes. MEWS systems should also include an escalation process, where if the provider notified about the MEWS vital sign does not respond within the designated time frame, care teams know who to contact next, when to contact them, and how. Here we illustrate our TCHMB recommended vital sign criteria and a tool to assist bedside teams with remembering the MEWS process. In previous presentations, we have defined 4 critical steps for MEWS implementation. The first is to educate all healthcare personnel on the vital signs and/or scoring system your facility has selected to trigger MEWS. The second is to create a specific response system in your hospital to MEWS triggers. The third is to create and educate on the escalation system chosen for your hospital. And the fourth is to collect data to track your outcomes. Today we want to focus specifically on how the electronic health record may assist or on occasion hinder you in your MEWS implementation, and how data is needed to drive improvement. I'm now going to hand over to Dr. Davidson.
Thank you, Amanda. Can you hear me okay?
Yes, we can.
Excellent. Thank you everyone for joining us today. I'm going to begin by going through some of the ways in which MEWS can be integrated into the electronic health record. Next slide, please. Next slide. Thank you. So I'm going to go through several examples of how it could be integrated or not integrated. And this first example is actually an example of choosing not to integrate MEWS with your electronic health record. In this process, the care team members are all aware of the vital signs that should activate MEWS. Care team members can reference the MEWS badge buddy if needed to clarify vital sign parameters or steps in the MEWS workflow. And so in this process, all communication between the nurse and the provider is done directly and immediately after the abnormal vital sign is obtained. And both the nurse and the provider document their respective portions in the electronic health record after the provider has responded to the MEWS trigger and a plan of care has been detailed. In this manner, data is tracked by audits and clinical collection. Next slide, please. The primary advantage of choosing not to integrate MEWS with your EHR is that there is no delay in the process. So there's an immediate recognition of the MEWS trigger with immediate notification to the provider. The primary disadvantage, however, to this process is that recognition of the MEWS triggers and thus subsequent provider notification could be delayed if the OB patient is being cared for in a unit that is not with primary OB providers. So for example, if your patient is in an emergency department setting or if they're in the ICU, those providers may not be familiar with MEWS triggers. And so there may be a delay in recognizing that the patient is deteriorating from what we know to be abnormal vital signs in an OB setting. So in that kind of situation, potential delays could be averted by having alerts or MEWS triggers from the electronic health record. Next slide. In the second example, this next example is utilizing best practice alerts or other similar alerts to notify care team members of the MEWS triggers. So if a vital sign is registered in the EHR that should trigger the MEWS protocol, the EHR would then create a best practice alert or some type of flag so that when the nurse or provider enters the patient's chart next, they're alerted to this vital sign. This could look like the first alert shown here, or alternatively, the alert may link to some type of OB chalkboard that is visible to everyone on labor and delivery and notifies the team members from there prior to entering the patient's chart. This option could also look like the second alert shown here if you have more of a scoring system rather than a single or double trigger. Next slide. Advantages to this process are that it eliminates the exclusive reliance on an individual to activate MEWS because it provides an additional layer of recognition to ensuring that a vital sign is not missed. So in more complex MEWS systems, like those that are based on more than one trigger or those that utilize a scoring system, this process may help reduce errors in score calculations or MEWS trigger recognition. Disadvantages include that it could rely on a care team member to enter the patient's chart in order to receive the alert. And so there could be there's an inherent delay in getting that abnormal vital sign and having notification to the nurse or provider because it would rely on the nurse or provider actually entering the patient's chart to get that alert. And lastly, it can train care team members to wait for the EHR to prompt them of worsening maternal conditions rather than recognizing those abnormal vital signs on their own because they're familiar with the triggers. Next slide. In this third example, this is where you could build a standing order set for MEWS, which can be used in either of the previously described processes. So in the first example, in which there was no integration with the electronic health record, you could still use the standing order set to be activated upon recognition of the MEWS trigger while either waiting for the provider to arrive to the bedside or once the provider arrives to the bedside and evaluates the patient and has a working diagnosis, then the provider could activate the specific order set tailored to the diagnosis. In the best practice alert example, the BPA could actually be used to link directly into the order set. Next slide. This option has the same advantages and disadvantages as those described in the prior two examples. One additional advantage to this process is that having built-in order sets for the more common diagnoses associated with MEWS triggers facilitates rapid diagnostic workup. It can be especially beneficial in settings where the expected response time for the provider to arrive at the bedside is 30 minutes or longer, but it can also be helpful for settings with shorter response times as well. However, this may lead to a high reliance on order sets without individualizing the care to the patient and their medical history. And this could lead to distraction from some of the less common but life-threatening conditions. For example, an order set that's built for fever and tachycardia is likely going to focus on a sepsis evaluation, and it may omit an important lab order that could speak to other differential diagnoses. And this, for example, could result in the failure to recognize thyroid storm in a patient with poorly controlled hyperthyroidism if you don't take her medical history into account when activating an order set. Next slide. This last example is full integration of MEWS into the EHR. And this process could involve a best practice alert that would be triggered upon the vital sign entry of a MEWS trigger. The BPA alert could then open a MEWS documentation tool where the MEWS workflow is charted, and this in turn would lead to activation of an order set specific to the charted abnormal vital sign. Next slide. Because this process is entirely based on the EHR, it has the same advantages and disadvantages as the previous EHR-based examples, but an added benefit of full integration is that the MEWS documentation tool is automatically prompted when the electronic health record recognizes a MEWS trigger, and it eliminates the need to chart MEWS information separately. It also helps ensure that the documentation actually does occur. It is important to be aware, however, that activating an order set based on vital signs alone, again, could lead to a diagnostic workup of an incorrect diagnosis because there's overlap in abnormal vital signs. For example, in a woman with tachycardia and hypotension and even oliguria, she could have hemorrhage or sepsis. So the diagnostic workup should consider the full clinical picture and the physical exam findings in addition to those vital sign abnormalities. Next slide. And while not truly EHR-based MEWS processes in and of themselves, we also wanted to highlight two other opportunities for using the electronic health record for MEWS implementation. The first one on this slide is to incorporate a MEWS flow sheet in order to quickly and concisely document the MEWS process. This option was mentioned in the previous example discussing full EHR integration, and this is an example of what it would look like when it's completed. So for example, the MEWS trigger is a systolic blood pressure of 80, and that gets charted in that point, and along with the time that that MEWS trigger occurred. And Dr. Epps was the provider who was notified of the MEWS trigger, and she was notified at 4:20 p.m. She was at the bedside at 4:26 p.m., and then an intervention occurred at 4:45 p.m. So this is a flow sheet that can be then used to run audits and get more information from your electronic health record. Next slide. This is an example of an audit process that was created specifically that Dr. Epps created for her hospital. So I'm going to turn it over to Dr. Epps now to talk more about this example and then take us through our data slides.
Thank you. So this final example is just another tool that you can use within your electronic health record, and it would be allowing you to do an audit from the information in your electronic health record that you can use to evaluate your process. So as an example, for my hospital, we created a report that went and extracted patient vital signs that would have triggered our maternal early warning system. And we had this created for every area that we take care of pregnant women. And then it would evaluate and pull from our flow sheet, which we use similar to the example that was in the previous slide, to be able to see who was notified, what time they were notified, and when they were at bedside. And then we also pull the vital signs that have recovered or normalized and what time those were. And from that, we use this for a lot of our data elements that we do for our PDSA cycles. And this is another good way that an electronic health record can help you with your MEWS process, in particular with evaluating the effectiveness. Next slide. So that transitions us to the using data to drive improvement portion. So by now, either because of experience that we've all had with our hospitals in quality improvement or through participation in Texas AIM, we've done a lot of talking about the model for improvement and PDSA cycles as a possible tool for evaluation of your progress. And we think that evaluating data is critical to see if your plan and your implementation has been effective. So for example, if your team has decided to implement a maternal early warning system within labor and delivery as the first area where you're going to try this system, and you educate all of your team members and you have built in the way people will notify based on vital signs, and then you go back and evaluate the data that you've been looking at and see that every time a patient is in the post-op area with a C-section, you're not firing your maternal early warning system because the team is picking to notify the anesthesiologist, for example, as opposed to who you've designated as your provider to be notified from your obstetrics team or whomever. This will allow you to go back and realize we need to provide further education and coach people to be able to follow the protocol. So using your data allows you to reevaluate your plan, make a new plan, and continually improve. Next slide. So for anyone who has participated in the AIM learning sessions or in our reinforcement cohort, these are examples of some of the data elements that we've shared previously. And they're things that you could use within your own hospital to track your maternal early warning system. So these data elements are broken apart into process, structure, and outcome measures. And for example, under process measures, it might be the cumulative proportion of providers, and that would include physicians, midwives, nurse practitioners, anybody who's doing OB care. How many of them have been educated on your system's maternal early warning system? I think some valuable process measures to consider would be the percentage of the patients in your system that are triggering your maternal early warning system. And then another very important measure is, of the women who should have triggered the maternal early warning system, how many actually did? In other words, if a patient has a blood pressure of 160, they should have triggered your maternal early warning system. Did that actually occur? And that will allow you to go back and figure out where your gaps might be and where you can strengthen your process. For structure measures, we recommended maternal early warning system protocols. Do you have one, yes or no? And are you including the trigger in your handoff report? In other words, as you're changing from one shift to another, is this an important piece of information that is conveyed to your teams? As far as outcome measures, obviously the point of these is what will help improve your process, but some examples that we would recommend include the time from an abnormal vital sign to having your provider at bedside, or if your maternal early warning system allows firing of a standard order set, then it might be the time to the order set. Another thing would be the time from the abnormal vital sign until it returns to a non-trigger range. In other words, goes from a blood pressure of 160 to one of 140. And then overall, the percentage of patients that are getting transfused greater than or equal to 4 units, and the percentage that are admitted to your intensive care unit. Next slide. On our TCHMB website, we have some documentation tools. So while we explained in electronic health record integration, you might be able to build a way to pull this or extract it from your medical record. It can also be done on paper. And I think there's real value to starting your process in paper before you've integrated it into your electronic health record, because it's a little bit more facile to adapt and change. So this is an example of a MEWS documentation tool, where if a patient, you're reviewing, say, a chart that has happened retrospectively, you can go through, did this patient have a maternal early warning system level vital sign, yes or no? And if yes, what was the trigger? And then going through and figuring out all of the pieces of information that would allow you to create those data elements. As an example, we did this with my hospital, and it took me about 5 minutes to complete the process, although I'll say we have a flow sheet that we use for documentation, and that helped. But you can find all of the elements here, and it also can help to prompt the teams, if they're using it at the same time as the event, to properly document. Next slide. So here's an example of areas where you might be able to collect this information. So for example, transfusions greater than or equal to 4 units, if this is the outcome measure that your team is using to determine if your maternal early warning system is having the effect you desire. You could pull this from interaction with your blood bank. Many of them will collect the amount of transfusions, and especially large transfusions. ICD-10 codes for severe maternal morbidity will capture transfusion. It does not break it apart into 1, 2, 3, or 4 units, but it will give you a smaller subset that you can review to figure out how many got greater than or equal to 4 units. It is a provider preventable condition for Medicaid, so many of your hospitals may be collecting it. They report postpartum hemorrhage and postpartum hemorrhage with transfusion, so that would give you a smaller number to be able to review to figure out how many got greater than or equal to 4 units. You can train your clinical teams to capture this, for example, having it part of handoffs from charge nurse reports or end of shift reports if your hospitals utilize these, collecting how many patients and who they were may have been transfused greater than or equal to 4 units. It might be something that you ask your hospital to put in an incident report, or whatever way you all track events as they're occurring. And then finally, chart review, and if you're looking for a smaller subset, reviewing the cases of postpartum hemorrhage to see how many of them had transfusion. Honestly, I think there's value in all of these and potentially using a couple of different ways. None of these will probably collect all of the values. For example, coding data is known to not always collect everything. And clinical capture, while prospective and often sometimes more meaningful, you might be able to collect cases in both of those settings that you didn't with the alternative method. And so sometimes it's good to use more than one. Next slide, please. Other important things that you should consider collecting, either by finding them in your flow sheet or creating phrases that providers can use for documentation. For example, when your responding provider comes to bedside, you might be able to create a standardized note template where they're filling in all of these things, or where the nurse who is notifying the provider is filling in all of these things, and something to think about as you're creating your process so that you have a way to be able to pull this valuable information. So things that are important that you might want to include either in a flow sheet or in the note, the vital sign that triggered your maternal early warning system and what time it occurred, the location of the patient. We definitely have noticed different processes and different types of pathology occurring in different areas, the time and the person who was notified, the time that that provider was at bedside or the time the order set was initiated, the time the vital sign becomes normal or is no longer in the maternal early warning system range. And being able to pull all of this will help you both with your process and with your outcomes to make sure your implementation is effective. Next slide. So here's an example of what you might do with this information and how it might help you improve your process. So if you're collecting the process and outcome measures that we mentioned, you might see, for example, as your implementation is progressing, the time that it takes for vital signs to become normal or no longer in MEWS range is slowly decreasing. That tells you people are probably using your process. If you find that that time is not improving, then you might be able to drill down into those cases and be able to give the providers involved feedback about where areas might have been missed. The bottom left graph is showing the maternal early warning system times. So in this example, as the time for the provider at bedside is slowly decreasing, you also might be seeing the cumulative proportion of patients triggering MEWS improving and overall your outcomes improving. So the point of these measures is really to be able to improve your individual hospital's experience. So for example, if you define an ICU admission as anyone who requires mechanical intubation or mechanical ventilation, or a pressor, and those are the people that are going to the ICU in your case, tracking that over time will allow you to see if MEWS is leading to improvement. But if another hospital has a different definition, and anybody that requires any kind of IV drip or arterial line or any other intervention goes up to the ICU, it's still valuable to be comparing over time your definition of an ICU admission to see if it's leading to improvement in your process. Next slide, please. So with that, we wanted to take some time for questions and answers. And with this, we can do overall maternal early warning systems, and in particular, the electronic health record integration and the data elements that we talked about. And Amanda, I'll turn it back over to you.
All right, thank you, Dr. Epps and Dr. Davidson. I haven't seen any questions come through during the presentation, but if you have any now, you can use the Q&A box down at the bottom or the chat box if you have any questions or comments. We'll wait just a few minutes to see. Okay, I see one question here. It says, what is your suggestion for auditing charts for MEWS triggers? Do you recommend going through charts for every vital sign while in labor and postpartum?
I can take this to start. A I'll tell you the way my hospital started evaluating it and then what we evolved into. So for our audits in the beginning, before we implemented our system, we audited all of our charts over a 3-month period of time to see how often patients were triggering and what happened in those cases and are the vital signs that we're choosing appropriate for our population. So then after we implemented, we did the same thing and we reviewed every single chart of every single patient. We had a pretty large task force. I think pros of that included when we were going through every single chart, it really allowed us to see what was truly happening. And I think that was invaluable. We didn't create a flow sheet at the beginning, so it was a lot of manual time looking at every single vital sign that had occurred to see if it would have triggered MEWS. And I think if I could do it again, I would have created that flow sheet so that we could just go and pull from that from the beginning. So after we had audited all the charts, then we went to pulling it from an electronic tool, which is the one we showed, where it was kind of an automated process, and then only reviewing the charts of those that didn't trigger our system and should have. I think they both have pros and cons. I'm glad that we manually went through them all in the beginning because I think that that was pretty critical for us to understand what was really happening. But now we wouldn't have had the time to devote to it because we're doing some other QI projects. So I very much appreciate having an electronic health record. It, I think, does depend on your implementation. Are you implementing it everywhere? Are you implementing it in a small area first, and what your delivery volume is and how many patients trigger your system? But first and foremost, I think recognizing when people are actually triggering it and when they're not, when there is a MEWS level vital sign is pretty critical, because I think most people have expressed, you educate everybody, think that they are triggering MEWS as they should, and then as you review, you find all these missed triggers, and those are obviously things that you can really improve on.
And the only other thing that I'll add to that is that at my hospital, we haven't really started doing consistently the missed MEWS triggers yet. But in the beginning, for the past year, actually, we've been auditing the known MEWS triggers. And so going into the chart of every single patient that we know activates MEWS and filling out a form similar to the one that we presented in this webinar of all of the information going on with that for that particular MEWS trigger. And that was able to allow us to find kind of some broken parts in the process to modify the system going forward. So, the audits can be used to fix the process you already have, and then also to get data about the outcomes of your patients. And in the scenario that we have where, or that I just described, where we were auditing the known triggers, that allowed us to go back and find different points of education. Like, for example, there was a patient very early on in activating or in going live with MEWS where she was being taken care of by a critical care provider who was not notifying the OB provider of what was actually going on. And when the OB provider got involved much later, there was a completely different diagnosis made, and the patient ultimately had to go back to the OR with a hemoperitoneum. And so that made us realize that there were some units that we had said, like say in PACU, the anesthesiologist could be the MEWS provider, and in the ICU, the critical care doc, because we have an OB ICU, the critical care doc could be the MEWS provider. But then we realized, no, across the board, we always need to have the OB provider, a responding provider, in addition to anesthesia and in addition to critical care. So it was finding those broken parts from the audit process that made us go back and make some changes and do some re-education.
Thank you, Dr. Epps and Dr. Davidson, for that answering that question. We do have another question that has come in, but before we get to that one, somebody did ask about the website to access the tools that we just talked about during the presentation, and that is our website, www.tchmb.org/MEWS. I've also put it in the chat box so you have a link directly there. But the next question comes from a rural hospital who has about 120 deliveries per month with only one person to audit their charts. They're asking, how do you recommend they do the auditing? They already have MEWS active and it uses a BPA, but they're having trouble getting that data out of Epic.
So
Sorry. Christina, go first.
Well, I was just going to say, I guess it depends on what your approach is. We talked about the auditing, doing audits of the known triggers and knowing how many patients per month are activating your MEWS. So it looks like you already know that because you have it built in as a best practice alert. So you would be able to just say, okay, out of 120 deliveries this month, I had 10 known activations, and that's how you got your percent. But in terms of going in and maybe doing random audits to figure out where there are missed MEWS opportunities, you could, I think it's probably, not feasible for one person to go into 120 charts a month. So then you could pick some consistent fraction of the number of charts a month that you wanted to audit. So for example, you're going to audit 30 charts a month, and you're going to look into them and see how of those 30 that you randomly selected, how many of them activated MEWS and how many should have activated MEWS that didn't. Do you want to add to that, Dr. Epps?
Sure. I think I would have said largely the same thing. The only other thing that I would add is I think I often worry about asking multiple other people to help with QI, knowing that we all have a lot of demands and often we're wearing a lot of hats. And I think especially in rural medicine, you're often stretched in covering multiple things. Recently, we've been doing a lot more of asking our bedside nurses to participate in QI and giving them kind of a defined point of reviewing just a few charts. And I have been very surprised at just how really, really valuable that is for them to be able to improve their process and their documentation. I don't think you realize some of your gaps. I've done this with my own charts where I've been reviewing and not realizing I was the provider. And then as I'm reviewing, I'm going into it and seeing the things that weren't documented that I'm looking for. And then, of course, surprisingly been, oh, this was my own chart. This is a pretty important thing to realize what I'm missing. And our bedside nurses are, I think, noticing the same thing, and it helps make them better with documentation and response and really more part of the process. So that was a long-winded way of saying involving more people actually helps and makes them more invested in the process. So if you can, giving people smaller, you just review these 10 charts today, often is very helpful.
And I would completely agree with that. I think that's a very important point, that the known MEWS triggers that we've been auditing at my hospital have been by the same two people. But now that we're wanting to move into a lot of random audits, we are actually going to divvy up that work amongst bedside nurses who, may only get 10 charts a month to review versus, one person having to review 30 charts.
And before we move on to the next question, I want to add to that as well. I also completely agree. We've heard from hospitals that actually use that as a tool to help train new nurses on their floor about how to appropriately document. So if you have any new nurses coming through, you can use that as both a labor support and a training strategy, and kill two birds with one stone. And I also want to stress that for quality improvement, you should shoot for a minimum of 30 a month. If you can do at least 30, that's a great goal to target. Moving on to the next question, it says, what, if any, challenges have you experienced in implementation in your emergency department, and how did you address them?
I can take this. So my hospital is largely an adult medicine hospital, and our ER is pretty big. We have a policy where any pregnant woman over 14 weeks automatically comes to our OB triage. And it is supposed to be that any postpartum patient with signs of preeclampsia immediately comes to our OB triage. We initially thought that would cover all of our scenarios as long as we had really hardwired our maternal early warning system in our OB triage. And of course, the way I'm phrasing it means we realized all the gaps in that. One of the things that we recognized pretty early is we hadn't done any education with the ER, and we had a lot of postpartum, not a lot, but a reasonable amount of postpartum preeclampsia coming through our ER with really high blood pressures. And it was not being recognized and treated in the manner that we would have in our OB unit. So my hospital does not have MEWS integrated as a best practice alert, meaning our system is completely dependent upon our nurses being educated on the vital signs. And so that was definitely a gap when it doesn't fire in non-obstetric or, in non-obstetric areas. You're really relying on having educated them. And I think that's a major pro to having it have some kind of an alert when it occurs. So we went down and did education with the ER, and I went to their grand rounds, and we're a residency program, so their didactics, and really walked through preeclampsia, severe range blood pressures, our abnormal vital signs, and when to respond. And then we've done similar things for a few other subject matter areas, but never tackling it like as a whole. And I think that's a real gap for us still. And I think integrating it so that it flags in anyone who is pregnant or postpartum is really important for especially ICU and ER and things like that.
And I can add on to that an experience in a different hospital setting. So my hospital is completely a women's hospital. So no matter what gestational age you are, and whether or not you're still pregnant or postpartum, you're going to go to the same unit, which we call the Women's Assessment Center. But one of the barriers that we encountered early on was kind of a thought of, well, this patient was just sent over from her doctor's office for elevated blood pressure. So we know her blood pressures are elevated. Why do we have to trigger a MEWS when she gets into, into the unit? And so the education around that was that it has to be treated. And so it's not enough to just say, okay, well, we know to anticipate she's going to come over here with elevated blood pressures. The reason that the doctor is sending her is because there aren't, medications to be used in the doctor's office in that setting if you need to give something for acute severe hypertension. And so it was kind of a retraining of the thought process of, even though these are all OB providers seeing and evaluating these patients, there still needs to be a different response to someone who walks in with one of these vital signs than someone who was sent over from their doctor's office and they just have mild range blood pressures and just need continued monitoring.
All right, thank you. I don't see any more questions at this time. So I guess that concludes our presentation on MEWS implementation. This webinar will be posted on TCHMV's website. It was recorded. As soon as that's done, you'll be able to view it. It will probably be a few weeks from now, but it will be available to view soon. Please don't hesitate to contact either Dr. Epps, Dr. Davidson, or myself if you have any other questions or if we can give any assistance to you in the future. We want to thank everyone for your time today and enjoy the rest of your day.
Thank you.
Thank you.